I'm happy that I get this opportunity to talk to you today. What I thought I'll do is just update you about the situation in Sri Lanka and what that means, and about the vaccines against variants. I mean, how effective are they? Because that's the biggest question I think everybody wants to know. And how do we move forward from here? Like, what does the future? What is the future going to be like? I think that's the most important question that all of us are interested in. How do we move forward? Now, everybody knows that we are not doing well. I mean, that is no secret. So this is just a comparison of the confirmed COVID-19 deaths per million people, because you have to compare with the population. And you can see, so we know that Indonesia was not doing well. It was having a terrible situation. Malaysia is also not doing well, and this is just Sri Lanka shooting up. So basically, as you can see, when we compare to the region, so this was the India massive wave, which we saw a lot of devastation in India. Of course, they were underreporting the cases, the deaths. We don't know how accurate our data is regarding the deaths, but we are having a bleak situation compared to Pakistan, Bangladesh, Nepal, and of course, I put in there UK and USA for comparison. Thailand is also having a bad state, but I mean, we are really not in a good state right now. And so why are we in this situation compared to other countries in our region? Is it because they don't have dangerous variants like Delta, and whether it's because of vaccine coverage? So let's look at that. This is something I really don't want to show, but again, a sad reality. It's not reality. I'll discuss what this actually means, which is moving case fatality rates. So case fatality is the number of deaths over a number of cases. And so when you put number of deaths over number of cases, unfortunately, we are very much leading. Okay, so this is again the same countries that I showed earlier. And you can see the case fatality rates in all these countries. Indonesia did have high case fatality rates, but Sri Lanka is on the top. Okay, when it comes to moving case fatality rates, and that is even sadder. And I'll just explain what that means as well. And when it comes to variants, I mean, if you take Indonesia, okay, USA for some reason I forgot to put it here. I mean, in all countries, Delta is dominating. Okay, and Sri Lanka, as you can see, again, Delta is really dominating. In the Western province, it is over 90%. We don't actually know how prevalent it is from the rest of the country. We are the only genomic sequencing lab, but we don't get representative samples from all over the country. We have been trying to do this for a long time to get representative samples, but then there has to be some national coordination getting samples to us so we can actually talk about the whole country, and this has not been happening. Although everybody has been talking about this. But nevertheless, in the Western province, I can confidently say that over 90% is Delta. And we know that what we see in Western province is a little bit different from other provinces, and cases are coming up in other provinces. So as far as Delta is concerned, the other provinces are lagging the Western province for about 4 weeks. So they will reach the situation of Western province in about 4 weeks. So it's difficult to say without the data, but this is just my understanding from what we are seeing right now. So when the other provinces catch up with Colombo, then we can think about what the situation can be in that case. Now, this is again how the share of COVID tests that are positive. Now, I'm showing this to you because other countries, when they list Sri Lanka as, red list Sri Lanka, or put us on the green list, they decide on things like a lot of things, which I'll come what they decide on. So the daily COVID-19 test positivity rates. So according to this data, I mean, it's around almost 20%. According to the Ministry of Health data, it is actually 25%. This is the release data. And our positive, I mean, okay, Nepal, Indonesia, and Bangladesh positivity rates are higher, but we also sit around there. And these are extremely high rates compared to countries like India, Pakistan, and the UK. And so somebody might say that, okay, India is not testing enough, but actually and not reporting properly, but they actually have low positivity rates, and their test per 1,000 people is much higher. So I can show you what I mean. So this is the COVID test per 1,000 people. Okay, and so this is when it's less than like 1 or 0.5, and we know like countries like Australia go really out and test, and so does Europe, and it depends on your resources as well. But if you look at the region, India and other countries, India is doing far more tests per 1,000 population people. So we know that the Indian population is so much more than us, but we are doing far less than India, and we are doing similar to some African countries and Latin America. So that's how we sort of stand as far as COVID tests per 1,000 people. So to summarize the situation, okay, so we do have very high deaths per million individuals, and we have the highest case fatality rates, that is number of deaths over number of cases due to COVID-19, unfortunate, and we have very high positivity rates and very minimum testing. So that is the summary of what I'm talking about. So I'm not going to talk about the public health implications of this because I don't about how this data is needed for planning, deciding on when to close, when to open, and all that. I won't go into that. But why does this matter from an economical point of view? I thought that might interest the audience better for things like how do countries red list other countries red list countries. So what are the criteria? So this so a lot of there is the CDC from USA, and from UK it is the Public Health England, and which gives out the guidelines for UK. And there are several countries in the world who don't bother to do it themselves, but just take advice from the Public Health England, and they just follow CDC or Public Health England guidelines in red listing countries. So basically, when they think about putting countries in, so there's a traffic light system. So red is a dangerous country. I mean, so you don't want to get passengers from that country, and you would strongly advise against your citizens visiting those countries. So when the test rates per 100,000 population, weekly case rates per 100,000 population, test positivity, evidence of variants, and genomic sequencing capabilities. So when you look at these things, so now when you look at these things, it will take a long time for us to come out of that being red listed. So we are red listed from a lot of countries. So we know we are trying to sort of revive the economy and get tourists coming in. But as far as the getting tourists down here, when their countries issue very strong warnings against traveling to Sri Lanka, and also when we have such high case fatality rates, people are going to think twice before coming to Sri Lanka. Now, why do we have high case fatality rates? So poor reporting of actual cases. Okay, so either not collecting relevant data, or not testing, or actually not reporting the actual positivity rates, which is sad, because if the actual positivity rates could be 20,000, 30,000. So if these were released, then our case fatality rates would go down, but not the proportion of deaths per 100 million, 1 million, of course. And of course, when you do have high case fatality rates, that does indicate that the hospital system is overwhelmed. There are not enough ICUs. We know that everybody, that is no secret. Problems with oxygen, which we are having. I mean, ships have been sent to India, and we are importing oxygen. So in some hospitals, I know, speaking to doctors, there are issues with oxygen, lack of drugs, and lack of drugs, which are again facing one of these lifesaver drugs, tocilizumab, is out of stock right now. Then having beds alone is not going to solve issues. Like, you can have beds and also all these ICU equipment, but then you have to have trained staff available to care for patients, because that sort of high dependency care needs special training. So you can't just have people, some random people, beds and all the equipment. It's not going to work like that. And of course, poor risk communication by authorities. It's important to actually say, okay, these are the what is going on, so that the public get the true picture, and they are going to be more careful. And also, when you're planning work and everything, when you know the true situation, then you can plan work accordingly. Now, I thought it's important to show this because the chances of somebody dying, because even every day, I mean, I get several calls asking, you know, I have a 80 plus person in my house. Should I vaccinate that person? Even now, people are, that person has diabetes. Should I vaccinate that person? Okay, so now the reference age group is taken as 18 to 29. So compared to the 18 to 29 age group, somebody in the 75 to 84 age group has 220 times higher risk of dying. And if you're, of course, over 85, you have a 630 times higher risk of dying. Okay, and if you are younger than this 18 to 29 age group, the risk of is 16 times lower in 5 to 17-year-olds. So you can understand the risk of dying of a 5 to 17-year-old compared to, you know, the older you get. Okay, so this is a really important piece of information put out by the CDC. 2020 April or May. So it's a long time ago that this data was available as who is going to die, who is at risk of dying when they get COVID. And when you look at Sri Lankan data, so this is as of 6th of August, you can see, of course, it's mainly the older people who die. And in Sri Lanka, unlike other countries, there is a considerable proportion of people in their 30s, 40s, and 50s dying as well, because we know that diabetes, hypertension, and so on are very significant risk factors that are associated with death. And of course, males, unfortunately, do have a higher risk of death than females, which is seen all over the world, and that is for biological reasons. And so if somebody, the older somebody is, and if somebody has comorbidities, there's no question about taking the vaccine. And this is why the Sri Lankan vaccine policy and the WHO and the vaccine policy of all other countries after vaccinating healthcare workers was to start from the old age group and work down gradually, because if you vaccinate these individuals, then you can drastically reduce the deaths, need for ICU care, need for oxygen, and all, and so on, so that you can actually manage the outbreak if you sort of save the people who are going to die. So unfortunately, we know in Sri Lanka that policy was not followed for some reason. The vaccine rollout in the early time when the AstraZeneca came, this group was left out, and it was the younger group, like 30 to 60, who were given. And then after a lot of commotion, after we sort of made a huge fuss, then it was 30 above. But then above 60s didn't come because now they were afraid. Then when the Sinopharm was rolled out again, it was not given to over 60s. Later it was given, but then people thought that, okay, you can't give the Sinopharm to older people or people with comorbidities. So, and then you are seeing the effects of these unplanned vaccination program, what is going on right now. Now, the questions I think that people want to know: do vaccines prevent symptomatic infection from variants? Okay, because what was told that when you get the vaccines initially, like last year, then you won't get infection. Okay, and we know that that is not true now. Do vaccines prevent death? Because we hear stories of people who got both vaccines and have died or are currently in ICU care. And can you still transmit infection after being fully vaccinated? Because we hear stories of everybody in the house who have got vaccines and they are going to work, and the elderly mother or father are at home. They are not leaving the house, and because they are not leaving the house, maybe they are not going to get exposed, so they won't get infected. Because but will those who are fully vaccinated transmit infection and infect those elderly people at home? And are all vaccines having similar efficacy? Are all vaccines the same? Now, there are so many different types of vaccines, so I won't just talk about the scientific side of it, but we know about these mRNA vaccines, the Pfizer and Moderna, which were first rolled out in the world. They were not used for any other illnesses before. Then we have these vector vaccines, AstraZeneca, the Sputnik from the Camellia, Johnson & Johnson, and CanSino Biologicals from China. And This is that they were used was from Ebola, which was again developed from Oxford. And then we have the inactivated vaccines like Sinovac, Bharat Biotech, Sinopharm, so on. And these have been widely used before, like for whooping cough, hepatitis, rabies, and the protein subunit vaccine, which you might be familiar, we have been using for hepatitis B. And this Novavax, the data is looking very promising, but it has not had got WHO approval as of yet. And now this shows, now if you remember the earlier graph I showed, where the US and UK have lower death rates, and we know that what US and UK looked like last December, January, where there were so many people dying, but in the UK, there's a significant proportion of people who are fully vaccinated, basically a lot of the adults. In the United States, there's a huge anti-vax campaign going on. So a significant proportion of adults are not vaccinated. So if you look at the data from US yesterday, over 1,000 people have died in US. And basically, majority are unvaccinated people who are older. Now, Sri Lanka, of course, we have an amazing vaccination program. We are just vaccinating in lightning speed. And some days we did like half a million vaccines given on some days. But the important thing we need to know is one dose is not going to give you protection. Okay, especially not against a variant like Delta. You need both doses to protect you against the infection, especially against Delta. And especially inactivated vaccines induce a lower immune response than other vaccines. So we know that we are basically rolling out Sinopharm is the main vaccine we are using. So people are only protected 2 weeks after getting the second dose of Sinopharm. So but along with this beautiful vaccination program that was happening in Sri Lanka, certain restrictions were also, all the restrictions were also removed in a similar manner in lightning speed, and we are seeing what happened as a result of that. So vaccinations are the way forward. There's no question about it. And we know that UK has fully opened, and although UK is having such a lot of cases, only very few deaths because people are vaccinated. So we can do that. We can do the same. We can open up as well, and COVID will go on. Everybody will get on with their lives once we achieve that. But before that, when people are not protected, when you prematurely relax certain restrictions, then you're heading for trouble, as we can see what is happening right now. Now, about vaccines and death, to answer the question, after both doses, can you still die? So vaccines actually reduce your chance of dying. So if you look at an 80-year-old, so an 80-year-old has a risk of 1% dying. So this is not with Delta, mind you. This was with the original variants. So once you are vaccinated, 80-year-old's risk drops to the same level as an unvaccinated 50-year-old. Okay, so an 80-year-old's risk is not going to fall to the same level as an unvaccinated, like a vaccinated 30-year-old. So still, older people are, even after vaccination, the severity of illness is reduced, the risk of death is reduced, but it's not going to be the same as a 20-year-old, unvaccinated 20-year-old. So in other words, an unvaccinated 20-year-old is so much times less likely to die than a vaccinated 80-year-old. That's how COVID unfortunately works. So even with vaccines, the risk is the same as an unvaccinated 50-year-old. So that's the important point that I wanted to make. So this is from Financial Times. And vaccines do work. So this is the second wave in the UK, where the number of cases, and you can see a huge number of deaths. But in the third wave, with the UK is experiencing right now, they're having 25,000, 45,000 cases or something like that. But this side is flat because the vaccines have very significantly, efficiently prevented deaths. And so now this is, if I just take you through this figure, so these were the actual admissions in the second wave of the UK, and they're experiencing the third wave, but despite so many cases, they have a drastic reduction of hospitalization rates. So this is the predicted admissions without the vaccines, if they didn't have the vaccines, but you can see what the vaccines have done. Okay, so this is how vaccines are effective. This is against symptomatic illness. Okay, this is against symptomatic illness. So with one dose of either Pfizer or AstraZeneca, so they have pooled the data of AstraZeneca and Pfizer together. So this is UK data. After one dose, the efficacy of preventing severe symptomatic infection, any symptoms with the UK variant or alpha, was 49%, whereas one single dose, the efficacy in preventing symptomatic illness for Delta was just 35%. Okay, which means 65% of people with one dose will develop symptoms. But with both doses, for the UK variant or alpha, it was 89%, whereas for Delta, it is 79%, which means 21% of fully vaccinated individuals will show symptomatic illness. However, we are not worried about symptomatic illness. I mean, if it was like a common cold-like illness with a little bit of fever, people that emerged in China, nobody would notice COVID at all. People only started noticing COVID because it caused severe pneumonia and death. Now, if we look at the vaccine efficacy against hospitalization, okay, so that is the important thing. With one dose, even one dose, it very much, even with the UK variant and the Delta, Alpha and Delta, one dose significantly has very high efficacy rate against Delta, and with the second dose, it is very promising. I mean, very good. 96% efficacy against hospitalization with Delta is fantastic. So this is data from the UK. Now, efficacy of Sinopharm and Sputnik for Delta, I mean, there is that data is not available. I know our university did a study on Sinopharm and also recently from Sputnik 1 dose, but that is to show how many people develop antibodies and the antibody levels. That does not translate to efficacy. If you want to look at the effectiveness of a vaccine or efficacy, you have to do a clinical trial or at least do observational studies. So currently for Sinopharm and Sputnik, there is no clinical trial data or observational studies, or even no observational studies in reducing hospitalization or death. Now, the last question, can fully vaccinated individuals transmit infection? So I will just talk you through this. Now, if you are, I mean, obviously, you know enough and more people who have had COVID by now, and I'm sure all of you have seen COVID PCR reports. Then it's impossible that you haven't by this stage. And in these reports, they give a CT value. Okay, so the CT value is an indirect measure of the viral load. So the lower the CT value, the higher the viral load. So this green line is the CT value or the viral load in the respiratory secretions of fully vaccinated people, and these are unvaccinated people. This is UK data again, and you can see there is no difference. This is a US study, again looking at CT values of unvaccinated and vaccinated people. Again, the viral loads are similar in early illness, but the vaccinated individuals cleared the virus faster, whereas the unvaccinated individuals' viral clearance was slower. So although vaccinated people and unvaccinated people have the same viral loads, so they can equally transmit the virus, the vaccinated people clear the virus faster, so they become less infectious faster than unvaccinated people. Now, the truth, okay, I don't know how many of you got your antibodies done to see if you have antibodies, if I believe all of you are vaccinated, but having antibodies alone doesn't mean anything. Okay, you have those antibodies should be targeting a particular region of the virus, and it's a so-called neutralizing antibodies that are important to prevent infection. But once you do get infection, there's these cells in your body called T cells, which are likely to be important. But again, how much important, we don't know. But for many vaccines, all the individuals make lower neutralizing antibodies, which are the important and the good antibodies. So this is why clinical trials are needed. Now, last slide and the important questions. So how do we move on? If anybody thinks at this time point we can eradicate COVID from the world, I mean, people were thinking about it maybe last August or somewhere down the line last year. But I think right now it is pretty obvious we can't eradicate COVID. It is here to stay. So in that case, how do we move forward? Because we know that breakthrough infections happen, some people who are dying. So in that case, do we have to give like yearly vaccinations? And if so, for whom? Do younger people need booster doses and so on? Or is it only certain category of people? So we don't know the answers, but the data coming from other countries or what they have decided is it's the older people who lose their immune response earlier, whereas the younger people actually maintain a very robust immune response. And so, like the flu shot, you know that in cold climates they give the flu shot every October to prevent people getting influenza and dying. So what they have planned is to give the COVID jab on a yearly basis with the flu shot, which might be needed on a yearly basis to the people who get the flu shot. Not everybody gets the flu shot because I mean, so many younger people get influenza every year and they're fine. And we know that after vaccination, so many, I mean, we hear of a lot of healthcare workers getting infected right now. Yes, a lot of healthcare workers are getting infected, but they're either asymptomatic or very mild illness. So in that case, there is no data showing booster doses will prevent infection. Okay, so we don't know if booster doses will prevent infection. The likelihood that all of us are likely to get naturally infected one of these days. So thank you, and I'm most happy to take questions. So
thank you. Thank you very much, Professor. I think it was an excellent presentation in layman's language. Very easy to understand your presentation. We really thank you for that. Now I will open the floor for questions with your hands raising. So this way we will have an orderly questioning of the doctor and Professor. Please let us know when your time's up, then we can close it because I'm sure there'll be a lot of interest. Sanjeeva, I think your hand is up. Would you like to ask the professor a question?
Yes, please. Hi, Nilika. Nice to see you. Is there any study or information on repeat infection? Because if it is going to stay on in the world, if everybody in the world eventually gets it, it will go out. But is it repeating?
Yes, people are going to get repeat infections. So studies in other countries have shown, because it's easier to do studies on healthcare workers and they get repeatedly exposed to the virus. Before vaccination came, there are studies in the UK showing that about 4% of healthcare workers who were infected got reinfected. Not a lot, 4%. And they had asymptomatic or mild illness. Nobody got severe illness, but that was with the same variant. Now with variants like Delta, they depending on the gap between the original infection and the subsequent infection, the severity can change. But basically, given that a lot of young individuals anyway without vaccination, we know that some people do die, even younger ones. We had 2 deaths in a 17-year-old and a 19-year-old recently who didn't have any underlying illnesses. So you do get these because the death is not zero. So when 1 million people are infected, you do get these things. But generally speaking, the reinfection rates are low.
Thank you. Riaz Sangani, you have a question?
Yeah. Thank you, Professor. Professor, this with regard to people who get infected, we hear some say about going through 10 days of isolation or quarantine, some say 14. And also I want to ask you is, why don't they do a exit PCR once a person is out of the quarantine? Why don't they do exit PCR? Also, one more question, Professor, is that do we build natural immunity? I think to somewhat you answered in different ways, but I'm trying to make it very direct. Do we build natural immunity once we get the COVID?
Yes, so I'll answer all those questions. So if somebody has mild or asymptomatic illness, after about 10 to 12 days, the person is not going to be infectious. Okay, so if the person had very mild illness, after 10 days, the person is unlikely to infect others. If they had like fever for 5, 6, 7 days, then it is best to stay for 14 days quarantine before so to make sure you're not infecting others. Now, whether you should do an exit PCR is like this. After you have COVID and you're PCR positive, you can shed dead virus for several weeks. So most in most instances, your exit PCR is going to be positive as well. You see, and in the earlier time point in the epidemic, people were only discharged from hospital when they had two PCRs negative 24 hours apart. So most of the patients stayed in hospital for over a month. Some people stayed in hospital for over 2 months. This is because they didn't become PCR negative for such a long time. So this is why the Ministry of Health has put out a circular stating after somebody becomes antigen positive or PCR positive, you should not repeat PCR or antigen for 3 months. Okay, because you can, after somebody is infected, your PCR can be positive up to 3 months. But you're not putting out infective viral particles after 14 days, so then you're fine. But if somebody is immunosuppressed or has had severe pneumonia, they can be infective for a longer period. I mean, obviously, such people will have to go into hospital. So this is why, so the guidelines for people who develop pneumonia are a little bit different. Then coming to the next question of natural immunity, yes, you do get natural immunity, but after a while, you can get reinfected, and most of the time, such reinfections are mild. Okay, so but if you are infected and have the vaccine both, then your immunity is very good, and you are very unlikely to get reinfected anyway.
Thank you, Professor. Moving on, Shreya, your question, please.
Thank you very much, Professor. That was so interesting. Professor, guys talk that if you mix vaccines, you have better efficacy. I was just wondering what the rationale about that is.
Yeah, so actually the studies were about mixing AstraZeneca with Pfizer or Moderna. So because those were two different vaccine platforms, so the first dose AstraZeneca with second dose Pfizer or Moderna, or the other way around, the immune responses were much better. So I think because those vaccines, when you give the same vaccine, it's just boosting the immune response from the previous one. Whereas when you mix and match, you are sort of getting a completely much bigger booster. So that is probably why you have more antibody levels. So you have more antibody levels, but the efficacy, there are no clinical trials to show efficacy. So I think that is really important to understand. Having very high levels of antibodies with the vaccine is one thing, but for efficacy, you do need a clinical trial.
Thank you, Professor. Manjula, you have a question?
Yes. Thanks, Professor Nilika, and thank you very much for accepting our invitation. Just want to ask you regarding the Sinopharm vaccine, because that's the one which a lot of people are getting in Sri Lanka. You mentioned that there haven't been adequate studies yet about its efficacy against the Delta variant. So is there a chance that some kind of a study could be done even here or somewhere else? Because this is something which is bothering many of us about the efficacy of this particular vaccine to reduce deaths.
Yes, so actually in the CMC area, because we are working very closely with the CMC and we have the data, so there is an ongoing observational study where, because we do all the PCRs for CMC also, so then it's easier for us, of the people, how many people who got 1 dose of Sinopharm or 2 doses of Sinopharm versus AstraZeneca develop, need to go into hospitalization or actually die. So the deaths have been very, not that way, I mean, deaths have been very low in the fully vaccinated people. So, but basically people who develop pneumonia and need to be hospitalized. So there is an ongoing study, but I think you can't do something like that very soon. It takes time to actually find out all these things. So maybe in about end of September we would know, but I think people want to know earlier. Okay, but you can't have that data soon because it's observational study.
Thank you. Hussein, you have a question? Hussein? Hussein, you have your hand.
Thanks, Vish. Thanks, Vish. Actually, my question, Manjula asked most of it. Thank you, Professor, for that very interesting presentation. Yeah, my question was on the same lines. Since Sri Lanka is relying mostly on the Sinopharm vaccine, and you said there is no study on efficacy. Now, you just mentioned now about the observational data. Is that likely? I don't know whether you're in a position to say whether we are likely to see the same type of efficacy levels as the other vaccines using the same route, or what is your best guess at the moment?
Yeah, so we can only compare with AstraZeneca, and given an equal number of population needs to be given. So this is why we have chosen the CMC, because we do have a large proportion of people who have been vaccinated with AstraZeneca in the CMC and the Sinopharm. So it's difficult to say, because right now there are enough people who have, you know, some people in certain embassies and you know, certain areas have also got Moderna and seem to be infected. So a lot of vaccinated people seem to be infected, but not in a bad way. But we need to actually find out how many. One dose of Sinopharm doesn't appear to be working, mind you. Which we know, because you don't get a good antibody response for one dose. There are enough people in the needing oxygen and so on who are in ICUs. But 2 doses of Sinopharm, we haven't had actually deaths as of. So the 2 doses seem to be actually protecting, but it's too early to say that. People who have had 2 doses of any vaccine are very unlikely to die unless, you know, they have a lot of other comorbidities.
Thank you.
Doctor.
Ganesh, your question, please.
Yes, Professor, thank you for this. The question is about children, because, you know, opening of schools and the, you know, future of illness in terms of affected children having, you know, long-term illness is one, and because we are not planning on vaccinating them. So this is a worry that every parent is having these days. So what would you like to say about that, Professor?
Yeah, so it's like this. So US is one of the countries which is vaccinating, and they are 12 to 18-year-olds. No country is vaccinating children less than 12 years because, first of all, there is no clinical trial data at all. So because there is no trial data, you can't vaccinate less than 12 years. So no country is doing that. But if we are talking about 12 to 18-year-olds, US is doing it, but the vaccine uptake is not great. That's a different story. UK and many other countries are giving vaccines to children with illnesses in that age group, 12 to 18. Children with cancers, children with diabetes, kidney disease, thalassemia. You see, I mean, so that group of children are getting vaccines in other countries. And I think in Sri Lanka also they are planning to vaccinate children with comorbidities. Now in the UK, what they have said is, although they do have option of going ahead and vaccinating healthy 12 to 18-year-olds, they are not doing that because they want more data. Because after all, this is an adult vaccine, the ones we are using, and the vaccine dose or the amount of whatever in the vaccine can be different for adults than in children. So children need a less of a dose for most vaccines than adults. So they're currently deciding whether children don't need 2 doses, whether 1 dose would be enough, and whether you actually use half a dose, 2 half doses in children, whether full 2 doses are too much, so a lot of people are actually thinking about it as well. As of Sri Lanka, we have had 11 deaths in children so far, and these 11 children, 5 of them were under the age of 9 months, and so they had various issues within the first 9 months of life. And the other 6 children who died, 2 children had chronic kidney disease, 1 child had leukemia, 1 child had undiagnosed type 1 insulin dependent diabetes, and the other child also had something like that. So it was actually not, you wouldn't say like healthy children. I'm not so, but of course, and of course, all other countries, we know that the UK, Europe, and all other countries have open schools. I mean, they're opening schools. I mean, they did have the term starting in Easter. Even UK had schools open, despite all this going on. Sri Lanka is one of the countries which continued to keep the schools closed, whereas other countries kept their schools open. I'm talking about European countries. because they thought that online schooling is not ideal for children. So we have to actually think about these things and balance these things when we decide. I mean, we are not in a position to open schools anyway right now. When we open schools, what is the best strategy?
Thank you. Anura, you have a question? Anura?
Thank you, Professor, for the enlightening presentation. Question, you mentioned that if you are COVID positive and you recover, that you might be PCR positive for sometimes even 3 months. How will that affect travel? Because most travel now requires a PCR test. Will
Yes, yeah, but then now a lot of places, even for Sri Lanka, you have to carry a report stating you are PCR positive on this day, and so you are still could be PCR positive. So if, like the day you are PCR positive, if you carry that report, you are allowed to travel. So that you had COVID. Even people coming into Sri Lanka, now we had cricket teams and so many different types of people coming to Sri Lanka, and some of them are PCR positive, but we had records that they had COVID like 1 month ago or two months ago. So then we know that it's the old infection that is just showing PCR positive, and in such instances, we disregard them as you know, like being patients. And even in hospitals, when people undergo surgeries, you know, like for routine surgeries or whatever, if they've had COVID 2 months ago or something, and you do a PCR and find them positive, we disregard that positivity, and they are treated like a non-COVID patient.
Thank you. Harsha, you have a question?
Professor, thanks for that very insightful presentation. What is the data you have on people, healthy people, dying from this heart inflammation condition called myocarditis or something like that? Because I've heard even without going into pneumonia, people have died. So what is the data around that?
Yes, so pneumonia is just one of the ways people die of COVID. And in Sri Lanka, people who die of other causes are sometimes not put as COVID deaths. So myocarditis is an important cause of death, which is inflammation of the heart muscle. So, and then you get chest pain and so on, and you can suddenly die. And also COVID thickens your blood. So your blood gets really thick. So then blood starts clotting. So then blood can clot in your heart, the vessels supplying your heart, and then you can get a heart attack. Although your arteries are healthy, because the blood just clots inside you, they can clot in your heart vessels, and you can get a heart attack. Or they can you can get this condition called pulmonary embolism. Again, that's another cause of death. So people can die of all these causes because of COVID. And so about children and this COVID issue with vaccines, it is extremely rare, but some of these mRNA vaccines do cause myocarditis in children as well. So this is why it's not a large proportion, it's a small proportion, but then you have to weigh the risk and benefit. Okay, if your child is not going to get severe COVID anyway, do you want to give the child myocarditis? But the risk is extremely rare. So this is why I think people want a little bit more time to weigh these risk factors before vaccinating children. But yes, so you can die from COVID in so many different ways.
Thank you, Professor. May I ask you the last question? And I know we have taken a lot of your time. There's a lot of confusion as to when we travel, that some countries are saying if you have this type of vaccine, you can come, or if you don't have this. How true is it? Does it really matter what vaccine card that you have to travel to Europe versus to anywhere? I think we are thinking it's a myth, but I don't know, what is your information that you have?
Yes. So for I'll start with US. US doesn't care if you got vaccinated or not. So basically, if you've had you know, these mRNA vaccines or the AstraZeneca, so people are thinking about Covishield, and if you have this Indian version of the AstraZeneca vaccine that you can't travel, that was because Serum Institute India hadn't applied for registration by the European medical authorities. they have got approval now, because you have to apply. You don't get approval without applying. So they have got approval. So even if you have the AstraZeneca or the Covishield, whatever that Oxford vaccine, you can travel. There is no issue. But if you're going to US after taking 2 doses of Sinopharm, as soon as you land in US, they give you 1 dose of Pfizer, Moderna, or something like that, and then after 4 weeks later they give you the other dose. US doesn't care. Canada does care. They would put you into the 14-day quarantine, and they would also give you the vaccines when you land. In Europe, countries like, I forget, Spain or certain countries accept any WHO-approved vaccines like Sinopharm and so on. But certain other countries, I think it is France and certain other countries, don't accept Sinopharm as evidence of being fully vaccinated, and they will insist you that you need to go into quarantine or something. But most countries want a negative PCR on arrival, because vaccinated people can transmit infection. And I think the reason that some of these European countries and Canada and so on, and even Australia don't accept Sinopharm and Sputnik. Sputnik is of course not WHO approved, is because, as I just told you, there is no data. So it is not that they are anti-China or anti-whatever. To make decisions, you need data. And because there is no data against efficacy against Delta, which we are seeing everywhere, I mean, that is the dominant variant, not just in Sri Lanka, in all countries in the world, then you want to know, okay, how effective it is. And so this is, so hopefully when this data comes out, there won't be any issue. But I think before you travel anywhere, we have to come off the red list. Because we are red listed in almost everywhere in the world. So until we get off that red list, we can't go anywhere anyway.
Thank you very much, Professor. Really, really appreciate you taking the time this morning. I think your explanation has relieved a lot of doubts that we have had. So thank you. Please do keep safe. And we really appreciate all the efforts that you're doing to keeping Sri Lanka safe. And do reach out to Ceylon Chamber of Commerce in any way that we can help your efforts. Thank you so much. Have a great day.
It was my pleasure. Thank you.
Thank you, everyone.